All right, I think we'll get started. It is my real honor and pleasure to introduce Jason Mercredi, who's our keynote speaker for the Opioid Use in Primary Care Conference today. Jason was, until recently, the executive director of Prairie Harm Reduction and has worked in citizen-based organizations for over 17 years. He is a co-founder of Canada's National HIV Testing Day, established Saskatchewan's first safe consumption site, which is a huge accomplishment, successfully advocated for the provincial expansion of the take-home naloxone program, established Prairie Harm Reduction's youth home programming, and has helped establish Saskatchewan's drug checking program. He is now the homelessness manager with Métis Nation Saskatchewan. Jason was born and raised in the traditional homeland of the Métis and Treaty 6 territory. He is of Denis Souliné Métis and Scottish ancestry, sorry for my pronunciation, and is a member of the Chippewayan Prairie First Nation. Thank you so much, Jason, for joining us.
Yeah, thank you for having me. So my name is Jason. I'm located here in Saskatoon in Treaty 6 territory and traditional homeland of the Métis. As you know, probably just from generally being in Canada, Saskatchewan's in a very conservative province, but yet we've been able to mobilize the province to introduce some pretty successful initiatives, including the safe consumption site in Saskatoon. There's an overdose prevention site that will be filing for to become a safe consumption site down in Regina. But they've been in operation for about a year now, and we've mentored them and worked with them, and we're looking as a province to expand these types of services over the next year or two. My role has switched recently, so I'm only on my third week of being at Métis Nation Saskatchewan. I've been brought over to be the homelessness manager, and so I oversee all the federal reach and home dollars, and then service navigators spread throughout the province. And really, we're trying to get some harm reduction programs and policies in place throughout the province now through Métis Nation Saskatchewan. And so that's a big shift. Working for a government organization when I've worked, or for a government when I've worked for community organizations for a while, but it's going to provide, I think, I'm hoping, some unique opportunities to mobilize a bit more. And it's especially good for me because it's an Indigenous organization and they're Indigenous government. And so I'm quite excited for this new opportunity, but I'm here not to talk to you about my current role. I'm here to talk to you today about safe supply, medical models, really not just around safe supply, but just medical models in general when we're dealing with addictions, and showing the approach, which I entitle "The Customer is Always Wrong." And so if I say anything that offends you greatly, I apologize, but I would encourage you to listen. When we're talking about addictions, the lens that I tried to view it as, because if you would have asked me 10 years ago, would I be the harm reduction guy in Saskatchewan, I would have probably said no, and what's harm reduction? And so it's taken a long time of me growing and listening and building up relationships to get to the point where I am today. And the example that I try to use when I'm telling people about the concepts that might be a little bit harder to hear, or some of the messaging that I say that you might feel personally attacked on, and you might want to go on the defensive, but I equate it to reconciliation often. And so I'm Indigenous, but I'm also a settler, and so I'm kind of operate in two worlds, and it's done me a lot of good for listening, because I'm a member of multiple communities within our province. So my mom's side settler, my dad's side's Indigenous, and we're both Métis and Dene, and so and it's pronounced Denisoulin, just for future reference. But when I'm working in communities, I have to keep all three hats on, and I also have to be open to listening to people that maybe have a different hat on, and they come from a different community, and they have different values and those types of things. But it's when we're looking at reconciliation, we do nothing without Indigenous people, and in fact, it's led by Indigenous people. And if we were to look at reconciliation efforts and talk about them being led by non-Indigenous people, it would take somebody with immense respect within the community that would be appointed by the Indigenous community to speak on their behalf and to really to drive those solutions forward. And it takes a long time to build those relationships up. And yeah, so that said, let's get started. So conflict of interest. So I have received grants from Vive Healthcare in the past when I was at Prairie Harm Reduction to do two projects. One was to do a play and one was to do a body mapping project, both around women living with HIV in Saskatchewan. And then I've also advised for Gilead in the past, maybe 3 years ago or 4 years ago, on a couple different projects. And so those are the conflict of interest I have to state at the start. And now, of course, I'm with Métis Nation Saskatchewan. So I want you to think about your day. So your ideal day, not like getting to work, but just your ideal day. And most of us, we start off with a coffee, and it doesn't matter where you live, you probably have a favorite coffee shop where you go into. And when you're going to that coffee shop, you go there because they meet your needs, your wants and desires for what you want that coffee to look like. And it's just something as simple as a cup of coffee to get your caffeine fix. But as we all know, we're all probably, or most of us are addicted to caffeine. It's not just about getting it in your body. It's a whole experience when you get a cup of coffee. And so you go into your favorite coffee shop and you order up your latte, your cappuccino, or your Americano or espresso, whatever you're ordering. You will have, and you're going to have that, when you order it, you have it a very particular way. And, all you have to do is go with somebody to Starbucks or ask somebody what their Starbucks order is. And they're going to give you basically a thesis on how their coffee's ordered. And if it's off by just a little bit, they're probably not going to be super happy. They might not say anything, but they're probably not going to trust you with that coffee order again. And you could go to a coffee shop with 6 people. Each of those 6 people is going to order something completely different that's unique to them. And we have to think about what it's like when you do get the item that you're looking for. You do get the drink that you're looking for. It completely makes our day. It makes us feel. It makes us feel human. It makes us feel like we're individualized. It makes us feel seen. And that's just something simple as getting your coffee order right and having choice around your coffee order. So let's talk about the different types of coffee shops that we see in the world. So, all right, so let's talk at first about Ye Olde Coffee Shop. So this coffee shop is ancient. It's been serving coffee since 2000. I purposely put that in there as a dig because I think we're all a little older than we think and like to admit. And 2000 was now 22 years ago. And sometimes when I think of 22 years ago, I'm like, oh, that's in the 80s. No, that's not in the 80s. That's in 2000s. But so we have this coffee shop, and they have a loyal customer base. So they've been operating since 2000. That's no joke to keep a business operating for 22 years and be successful. And so they've been operating with their loyal customers, and they have people coming in, and it's been fairly steady, and they're making money. The model works for them. Their model is much like a diner. So you come in, you can't get to go, you can sit down, maybe you order some food, you get your coffee. And in Saskatoon, we have a place called the Park Cafe. It's kind of a little greasy spoon, but it's where I like to go for my coffee. And I talk to the staff, and maybe I'm doing some work at the same time as I'm getting ready for the day. I have my breakfast, and then I go on. And that's a amazing business, and it makes decent cash. But the model is really worked. It was developed in the 2000s, and it worked for a long time. So you're starting to notice as you're running the business, and you're starting to notice that customers keep asking you for things that you don't offer, and you're not comfortable with the changes that they're asking you for. You might have to invest in some new equipment. You might have to redesign your counter space. It's not yeah, I know you guys would be much happier if I gave you this, but business is good. I'm still making my money, and and you guys keep coming back. So I'm not gonna do these investments and tweaks that you keep asking me for, because I like to run my business the way I like to run my business, and that's totally your right. And it's just fine with you that they are somewhat unhappy, but they're still happy enough to come back. The system works for you and your existing customers, but what you're starting to notice is there's been a bit of a downward trend. Okay, and then the pandemic hits, and you can't have customers in the way you like to have your customers in. They can't come down and sit down. The restrictions come in place, and your business model needs to adapt. And in the business community, the motto is always the customer is always right, and adapt or die. If you can't adapt your business model for the current times, whether the tech's updated, whether the service is needed or updated, your business is not going to last. And we've seen that throughout the pandemic. A lot of businesses that were very successful pre-pandemic have had to shutter their doors because they couldn't pivot and implement the things that they needed to do to be successful. But post-pandemic, it really worked for them. And maybe some of them have even lasted the storm. But if you were to talk to those business, and now we're on the other side of restrictions being lifted, you talk to some of them and business is not as good as it was. So maybe they're understaffed. We've all been to, I don't know what it's like in Ontario, but in Saskatchewan, I've been to diners and it's clear they do not have adequate staffing levels. And so you have to be a little bit more extra patient if you're a customer. That will only last for customers will only stay patient for so long before they come back and they think this has happened 3-4 times now. I want to move on. Yeah, pandemic's been tough, but tough shit. I want my coffee when I want it, and you can't provide it for me. And they're going to find someplace else that they can get their coffee from. So that brings us up to the new coffee shops that we're seeing, the hipster coffee shops, as they're often called. They can't keep up with the demand. It doesn't matter how much staff they have, how much beans they brew or toast. They can't keep up with the demand. They offer different models for service delivery. So they're not just offering services that are in the that are sit down and drink at the table. They have grab and go. You can order online. You can get Skip the Dishes to deliver, or DoorDash or Uber Eats or whatever company operates in your area. You can get it that way if you want. You can order online ahead of time, pick up, as I said. But they have multiple different options for their business, and they're making money hand over fist, but they're also reinvesting money back into the business, right? So they're constantly reinvesting money back in the business. And what's more is they are listening to their customers. And in fact, at the old coffee shop, you're starting to see that some of your customers are now going to this new coffee shop, and you're wondering why they are when they've been loyal and they've been accessing with you for a long time and using your service for a long time, and yet they stop going to your shop. And so their business model, that customer's always right approach, where they're constantly adapting the business model, and they're listening to what their customers want. And sometimes they don't want to hear what their customers want, but at the end of the day, it's a business and they need to make money. And so maybe they had to offer their beans in a select way. Maybe they had to change the cups that they were doing, but they're constantly reinvigorating their business and reinvesting. And so they're constantly busy. And this is like the newer model for running businesses. It's no longer, I want to run the business where I want to run it. They have some values that they're trying to keep, but really at the end of the day, they're trying to expand and try to make money, and they're hungry. So when we think of the old coffee shop, they've been kind of resting on their laurels, and they lost some of those skills, that adaptability around the skills of when they first started the business. Because when this coffee shop first started in 2000, it was the new guy on the block. It was the new scene on the block. And so they had to really hustle to gain that market advantage. And they really had to listen to their customers. They probably changed their menu a bunch of times, but something happened in the last 22 years, probably around the 10-year mark, 5-year mark, where they figured out what items they can make efficiently. They found out what food items they could make quickly, and that their customers came back for on the regular. But unless, most people won't come back for the exact same item every time. There will want to be some variety, and there's so many different people. And so something happened to that old coffee shop when it first started. It started to revert back to, this is safe. We know how to do it. We know how the system works. We know how to implement it. This new coffee shop doesn't have that advantage. So they have to keep up with the times. And so that competitive advantage that they have, that hustle factor that they have, that putting in the extra hours and really diving in, and they might go at a loss sometimes, but they know that that's what's needed. That money needs to go back into the company so that they can exploit the profits on the other side. And so when I think it's pretty obvious now when I'm talking about coffee shops, I'm actually not talking about coffee shops, surprise, surprise, at the opioid conference. I'm talking about the medical model for addictions. And so when we're looking at the models that are being offered in Canada right now, there are a lot of doctors who had to put in a lot of time. There's a lot of nurses, there's a lot of health experts that had to put in a lot of time to develop their model, and that's their baby. And when they first started, they were putting in those extra hours, and I'm sure they still are, because, you know, working in healthcare is no joke, and you can't just walk away. And so you're putting in the same hours, but the model has stopped adapting, and really we stopped listening to the customer, the patients. And you just have to look at what's happening across Canada to know that the system's not working. These setups that we have aren't working. And what's more is we have, because the medical models that we're dealing with addictions, it doesn't have the same impetus to adapt and change as a private sector business would. And the reason it doesn't have that impetus to change is because it's not about gaining new customers, it's about maintaining contracts. And so when you have a contract that you have with the government and relationships you have with the government, oftentimes we'll find that the folks that are operating these sites will defend it. And they will keep defending their program and talking about their program outcomes like they're good, and like that's the future model that needs to work, because they're only looking in their bubble that works for them and their existing clientele base, not this growing outside the door of customers or patients that need access to the services, but the services that we're delivering do not work for that population anymore. They work for the methadone, the methadoses, the Suboxones. They work for a small subset, but you look at what's happening with stimulants in Saskatchewan, you look at what's happening with opioids across the country, it's not working anymore. And I think it's pretty clear that most of the medical models around the opioid crisis are in this old model of service delivery, where they have not adapted, they have not kept up with the times, and they're no longer the new kids on the block. And we're starting to see the new kids on the block are starting to take off. The data coming out of the safe supply programs in Ontario, the data coming out of safe supply in Alberta, BC, you can't argue with these outcomes. They are incredibly good. They're incredibly cost efficient, yet there's a reluctance to embrace them. And a lot of times it's because we are comfortable with what we know. We're comfortable with accessing there, and we don't want to put in the work, or can't put in the work because maybe you're understaffed. There's always these million reasons. There's always excuses why we can't, but you haven't been able to keep your coffee shop or your addictions program up to the new level that's needed. And there's lots of reasons why we can't. We hear this often when we're talking about these types of topics across the country, whether it's kaput or whether it's us or whether it's you name it. Advocates across the country, we are constantly told excuses as to why it can't go down. And my motto has always been the same. It's tell it to the dead. And so I think, like, to be frank, I don't give a fuck why your program doesn't meet the needs and why it can't meet the needs. A lot of it is excuse driven and it's morality based. And like it's tough for me to, a lot of it is people aren't wanting to stick their necks out and their careers out on the line to really do what's needed to be done. And it's because it can be very isolating when you're on the front line and delivering these types of programs in community. And look, I built the consumption site in Saskatchewan. That shit is isolating as fuck, and it costs you a lot. Like, not just in terms of professional relationships, personal relationships, status in the community. It takes a heavy toll to be the innovator in your region on these areas, and to be the first one in your group to speak out and do the right thing and follow up with it and implement it, and then go to bat for it time and time again when you have all these pressures coming down on you. But it doesn't have to be. You don't have to be alone. And I say this is the new foundational approach, but it's not that new. It's been being advocated for so many years across country in all different sectors. And it's having people who use drugs at the table. That's step one on any time you're wanting to develop a new program, is you have to have people who use drugs at the table, and they have to be in decision-making roles. And you're going to hear shit that you don't want to hear. You're going to hear things that you don't want to deal with, but it's still important that you do that. And make the time and space and maintain those relationships. Because what people are saying they want more than anything, people who use drugs, is they want a non-toxic drug supply. keeping people alive should not be controversial. Yet for some reason, we keep making it controversial, and we let politicians keep making it controversial, when stopping people from dying should not be viewed as a controversial issue. And this image on the left is very, so this is a grain elevator. If you've never seen one, in Saskatchewan, they used to be across the prairies. Every town had one on the rail stop, and they were like these cultural icons on the prairies, and everybody clings to them. And we only have actually a handful left across the prairies because they no longer work. This is what our province was basically built on, was these grain elevators. And a lot of communities are tearing them down. They're either building new ones, or they have central depots, so that they no longer, each community doesn't have one. They have new state-of-the-art ones at central locations that people can bring their grain to. But we purposely chose this image on our clothing line at Prairie Harm Reduction because when we were looking at it, we wanted it to be talking about dismantling the old system and the new system. And so this was the most tangible example we could have from in Saskatchewan, which is the approach of just say no, or the abstinence-based approach. You can see the DARE logo burning as it falls to the ground there. That was very intentional from our point of view, because what we're seeing from the addictions community and addictions leaders, and I use that term loosely, is abstinence-only approach. And I myself live an abstinence lifestyle. It works for me, but it doesn't work for everybody. And people will cling to these abstinence-based approaches because it's what they know and it's what worked. And government will often consult the addictions community about how to address this, but who are they really consulting? They're consulting heavily in the NA and AA community only. They are not consulting people who currently use drugs. And all you have to do is look at the addiction scene between now and 6 years ago or 7 years ago. It's completely different. The substances are different. The level of physical addiction is different. We're starting to see the societal pressures get even heavier on in terms of poverty. Like, look at just how inflation's out of control right now. We're starting to see all these issues that are being really compressed. And then on top of that, the access and accessibility of legal drugs and the potency of those drugs. And so the information we're getting in on our feedback loops is not up to date. And so we're making decisions based off of outdated information. I myself lived in homelessness for multiple years, but that was back in like 2001, 2002, 2003. That's no longer relevant now. The completely different issues. I'm so out of touch with what homelessness looks like now on a personal level that I can't speak as the person with lived experience. Yet constantly we're having these people advise on these different projects who have not been, I don't get me wrong, I know addiction's an everyday thing, but they do not know the new context, and they don't know it intimately, and they often do not have the relationships in the community to speak on it accurately. And that goes back to step one of the new foundational approach of anytime we're building up a program, is having people who currently use drugs at the table. It's not that crazy. Organizations like Kaput and stuff have been advocating that forever. You talk about advocates across the country. This has been pretty straightforward. And so I can't stress enough that we need to go back to the basics of what it's like to build a social movement, and what it's like to build effective programming for populations. We would never do reconciliation work if it wasn't led by Indigenous people. Yet addictions is the one place that we constantly have work being done that is not led by the people that are most affected by it and that we're trying to represent. It makes absolutely no sense. I'm going to run a queer organization as a cis straight man. What the fuck am I talking about? That's exactly what programmers sound like when they talk about designing addictions programs, or government sounds like when they're talking about implementing drug policy, and they have not consulted the population that they're trying to support, or issues that they're trying to address. It makes absolutely no sense. Safe supply programs can look a million different ways across Canada. The reason I say to get people advising your program and your folks at the table, and I'm talking at board level, like of your organization, management level within your organization, not just in a consultation role. One of my biggest pet peeves is when I go talk to organizations. I can do a lot of consultation around Indigenous work within non-Indigenous orgs. And one of my biggest pet peeves is when they hire an Indigenous program officer, or an Indigenous consultant, or an Indigenous cultural worker, but yet 95% of their staff is non-Indigenous. You're not indigenizing the org, you're tokenizing it. You saw a grant and you got it. The same thing can happen with people who use drugs, but oftentimes we dismiss it and say, well, we got Jason, he's good, he uses drugs. But you actually, can I make decisions? Can I influence policy? Can I write policy? That often those things aren't happening. And so you need to have that foundational approach of people who use drugs at the table, so they can advise to you what your safe supply program is going to look like, because they will want safe supply. Fact. And if you're not trying to support them on the things that they are doing, you are no different than coming into a room full of Indigenous elders and Indigenous leaders and then telling them what they need. You can listen to them, but you're not actually implementing it. So you have to have that foundation. And then the decriminalization of drugs, I put that on there because there's work being done across Canada. Oftentimes there's not a lot of good consultation going on. I don't need to belabor the point of what's happening in Vancouver, what's happening with at the federal level, but or the lack of action at the federal level. But that decriminalization is there, but it's a low-hanging fruit. And oftentimes there's the bait and switch. We'll trade you out decriminalization and then safe supplies off the table. You can't do that. That's I call it the smallpox blanket theory, where you're giving me something and acting like it's a gift, but really what you're giving me is the same poison you've been giving me for years. And so I don't really stand for it. I think we need to be holding the people to account, but in order to do that, you have to actually listen to people who use drugs. And how are we going to get these things in place? Well, you need to get vocal. There's politicians in place. You need to hold them accountable at all levels of government. And you need to dictate the conversation because government's trying to meet government's needs. Government's not trying to meet community needs. Very rarely does those two things line up. And community needs won't become government needs unless we make them. And so this image is from the the AIDS movement in the 80s, where where people were just being told that they had to die, and they were told reasons why they could. People living with AIDS were not at the table making decisions, whether it was with government or pharmaceutical companies. And we're seeing the exact same thing play out in the addictions community right now. Yet when we talk about the AIDS movement, if you're talking about developing an AIDS program, a program that worked with people living with HIV, and you weren't including people living with HIV and having it ran by people living with HIV, you'd be laughed out of the building. And so, but yet with addictions, we keep having it, and we allow people to talk about past investments or record investments. That's pretty standard line that I'm hearing from governments across the country that are not addressing the fact that a record amount of people are dying. We have to hold them to account, and that's going to be very uncomfortable for you. And as I said, it might cost you a bit. And if you're not willing to do that, then just be honest about it. Just be honest that you're not willing to put your career on the line. I get it. You got mortgages to pay, you got kids to feed, you got partners, all that type of stuff. But for the people living through this, it really is life or death for them. It's not trying to find a new job or death for them. It's life or death. And so I think we need to be very mindful of that when we're doing it, but we need to organize and empower those groups and support those groups that are doing the work. And look, I'm involved with a lot of different social causes in Saskatchewan, and I can tell you that there's uncomfortable conversations that are continually happening. But you have to listen. And if I'm supporting Black Lives Matter, I need to listen to Black Lives Matter organizers and people that are living it. If I'm working on Indigenous issues, I need to listen to Indigenous folks. If I'm working with homeless folks, you get the idea, right? So that constant feedback loop, but they're going to tell you things that they're not happy about. They're going to tell you things they want to change. And we know change can take time, but you need to keep that tension of the urgency and the patience. But if you don't have that sense of urgency, I'm not keeping patience with you or minding that with you, because you're clearly just stalling. And that's fine. Just own it if you are stalling on these things. But you have to keep that tension in the community, and it's purposeful keeping that tension of the people with the incredible sense of urgency, but also the patience for systematic change. But you're kind of in a unique position in the medical community that you can establish these types of programming. You just have to kind of plan around it. The consumption site in Saskatchewan is all done on a fundraising model. So the whole site, it runs from 10 a.m. to 10:30 p.m. Monday to Friday. It's run on a fundraising model. So if PHR can fundraise enough money to run the consumption site on a fundraising budget in Saskatchewan for a very quote unquote, like progressive cause, there's no reason why you can't. There's way more money in Ontario than there is in Saskatchewan, and there's way more public acceptance on these issues. Maybe not from percentage of the population, I don't know, but from just the sheer amount of people and sheer amount of people with money. Plus, your province is way richer than our province. There's money to be had there. You can get safe supply programs and drug user programs up and running through fundraising and through being creative, but also trying to get the money out of the government. People will often not want to go out on the advocacy role because they are worried about their existing contracts. We all see what's happened in Alberta with the Kenny government, where they closed down harm reduction sites, and I think they need to punch back over there. The one thing that's kept PHR safe in Saskatchewan is we don't piss around, and we're pretty aggressive on our advocacy initiatives. Because that's what's going to keep us safe at the end of the day, is the public understanding what we do, being vocal about our needs. But you're not going to get it if you don't ask. And what we see is a lot of times people will say, well, I don't want to affect that relationship, or I've asked them and they said no, or I'm working on it, but it's pretty clear that the government's just stalling you. So you have to get kind of aggressive on those approaches. Otherwise, we're going to be stuck in this 1980s AIDS response for the addictions in the 2020s. And I feel like this is the decade that we should be making noise and major strides on these things. And you're going to need to keep up momentum and dedication. So this is my friend Zoe Dodd. I'm sure most of you know her. I'm sure some of you don't even like her and, because she comes at you and she tells you what's on her mind. But if you're not willing to listen to folks, you're not going to get anywhere, especially folks on the front line. And as somebody who's ran an organization, I can tell you it's tough being in the position where you got to make budgetary decisions, you got to deal with policy, you got to deal with boards, you got to deal with all these types of staffing, and you have people that are coming at you saying you need to do this or the other thing. But that doesn't mean that they're wrong. Just because you're tired or whatever, that doesn't mean that they're wrong. And it's important that we listen to folks and give them a seat at the table when we're talking about these things, because if we can get on the same page, we're going to actually get together. But oftentimes people in power positions think that means people on the front line need to listen to them. And I think it's kind of the opposite approach. You need to listen to them, and then you as a leader need to execute going forward. So I purposely chose Zoe because she's somebody that I respect deeply. She's somebody that I go to for advice, and I think she's the one that ruffles feathers. And the people that get shit done are the ones that are going to ruffle feathers, because if being polite and was going to get us anywhere where we needed to go, we would already be there. We wouldn't have to be fighting in the streets, organizing protests, dealing with the political backlash that we're dealing with in the harm reduction movement if being polite was going to get us there. So this goes back to on programming. I think it's important that we focus on outcomes. So when we're talking about outcomes, you need to focus on your program outcomes. And I've been just as guilty as of the next person, that when you're operating an organization or a program, or you're a board member for a group, you focus solely on your organizational outcomes for your reported outcomes. That is definitely important. You got to do that. But oftentimes what we're losing out on is the community outcomes. And so nothing's more frustrating to me in Saskatchewan than when I hear people talking about the fact that they're solving the HIV crisis or the addictions crisis, but they're not recognizing that our HIV rates keep being out of control and they're getting worse year over year. Our overdose rates and overdose deaths are getting worse every year. And yet we keep talking about it like the program is going to solve it, because we're not actually focused on the true outcome that matters, which is what's happening, not just in our building, but outside our doors. And so we really do need to look at this is the one thing I think public health is very good at across the board, and is looking at the metadata. And especially during COVID, where we hear governments talking about COVID's over, and then we're also still hearing that our emergency rooms are full. That's a good example that the medical community often can relate to when we're talking about your program outcomes. You're doing good, you're hitting all your outcomes, but what's actually happening for the community is still not good, and it's affecting the healthcare system. And it's something that oftentimes people in power don't want to talk about. And then you have to flip that and consider, if you're the person in power running an addictions program, where are you at on listening to the community about what you're seeing and saying, no, it's all fine, it's good, we're doing everything we need to. But then you have these terrible outcomes that are happening in your community for the population that you should be serving. It's not a great spot to be the. And so then to talk about the detractors, so there's people that want your movement to succeed, and there's people that want it to fail. And I think that there's a tension to keep. There's people that with some education, relationship building, they're going to potentially get on board. And I think it's great that we spend time building up that public education, that public acceptance. But then there's people that just want to keep you stuck in the mud and spinning your wheels based off of their approval. And I have, we have a pretty aggressive approach here in Saskatchewan, and it's proved us well. And so this is a meme off the Prairie harm reduction page. And it's a joke, but it's also a little bit serious, because we were dealing with a lot of backlash on trying to just get naloxone into the community by a couple of people in power. And they were saying that our communities don't need this, we don't have to do that. And so we took a pretty aggressive approach, and we're just like, we're going to carry it, go fuck yourselves. And on the front of Prairie harm reduction, there's a giant naloxone kit, because when we first built the site, that's where we were at. And so with that, I want to talk to you about the internal politics and call-out culture that can happen within the addictions community. So who amongst these people should be the leader or should be leading at certain times? We don't know. And they all have their own agendas. They all have their own concerns. They all have their own, and these might be doctors. They might be people who use drugs. They might be nonprofit organization leadership. They might be government leadership. We don't know. So who should be leading this conversation and who should be leading different projects and that type of thing? We don't know. And the way that we're going to know is by bringing everybody together within our communities, talking about it, making an action plan. That's where those tough discussions come in. I often hear people in the medical community saying, I don't want to do that because I'm just going to get yelled at or whatever. And oftentimes it goes back to that foundation of, do you have the people most affected at the table when you're building it and when you're implementing it and ongoing? And oftentimes people will say yes, but or no. Most of the times they'll say no. And so that's when call-out culture happens. If you don't have those people in your tent, having the internal discussions that need to happen and dealing with the internal politics that need to happen, then you're leaving them no recourse but to come after you publicly, because you've silenced their voice when it matters. And what's as a result is you're going to have program outcomes that are not as good, because you're only thinking about it from your medical model, not from the community standpoint. You have to have it integrated together. And so if the people are not in the tent to have those discussions, they're going to continue to have those discussions, and they're more than likely going to call you out. So it's very important to bring them to the table to have those discussions when we're developing programs and ongoing monitoring of programs. Easy for me to say, very tough for us to do in action, but I think it's incredibly important. And it's one of the foundational approaches I've taken when we were looking at mobilizing the community and building up the programming that we were doing and mobilizing the communities we had in Saskatchewan. And people will often ask how we've been so successful, to get harm reduction off the ground. It's because I'm talking to everybody constantly, and I'm getting told I'm an asshole probably 5 times a day. Because I need to learn, I need to sit back, I need to grow from this. But it's important for me to hear that. And I tell people all the time, I know I'm an asshole, but I want to be your asshole. And so oftentimes, how can we work together to accomplish these things? And it takes a lot of time and patience and that maintaining of the conversations and relationships. So here's a quote from Malcolm X, one of my heroes. You're not to be so blind with patriotism that you can't face reality. Wrong is wrong, no matter who does it or says it. And so this is a quote that I think directly applies to the medical community when it comes to addictions, is people are so caught up on being on the defense for what they're doing. They're not admitting that it's not working, or that the wider community, it's not working for the wider community. And then they're not willing to address the people that are saying the wrong thing. So if your premier, if your MPs, our prime minister, whoever's saying the wrong things, you have to be willing to engage with them and tell them that it's wrong. And when we were doing the consumption site advocacy, people would often ask, aren't you scared of telling the government? Aren't you worried about telling the government something they don't want to hear? And I said, I'm more scared of being around a government that doesn't listen to people that think differently than them, because or to put it in a more simplistic way, I'm terrified of what it means if our government can't hear from the other side of their viewpoint, what it means, because that means that they're going to be silencing us and doing all these things, and we're on our full way to fascism, and I don't want to partake in that. So I'm going to put up a stand on this, because this is the issue that I'm dealing with right now. And so a little bit simplified, but I'll thank you for your attending, and I'll be open to any questions. I haven't been paying attention to the chat, but I see that some things have been going in. If you're able to, I'd encourage you to donate to Prairie Harm Reduction. We're out on the front line. We do not have the same level of supports that even on Ontario that they do. It's isolating for that organization out here, and the connection across Canada really what makes it or breaks it. And if you can't donate, we have a new clothing line, or Prairie Harm Reduction has a new clothing line coming out in end of May, June for summer, and you can buy some clothing line, and all the proceeds there go to support the consumption site in Saskatchewan. So with that, I will stop sharing the screen, and I will open it up to questions.
Jason, we don't have any questions yet. A lot of thank yous and appreciation for what you've been saying. Thank you very much for a fantastic talk. As your title, even just the title suggested, it was provocative, and is exactly why the planning committee had invited you here. We have a couple comments that maybe you can respond to while we wait for some questions to come in. Yep. There's one comment from Shay about decriminalization with a 2.5 gram cumulative threshold, setting everybody up for failure. Can you give us your thoughts about thresholds for amounts carried?
Yeah, I just think it's a repackaged war on drugs. Yeah, so it's a repackaged war on drugs. With the thresholds, depending on, that might be good for some folks, but there's a lot of people that I think we all know that's not gonna get them through the day. And so every day they're at risk of being charged with trafficking, and some police forces are pretty progressive, and some aren't. And so I think it's pretty clear that this was led by law enforcement. It was not led by the community, and that goes back to it's not based off that foundational approach of being led by people who use drugs. It's just another paternalistic colonialism policy.
Thank you, Jason. We've got a question from Leah in Ontario. Leah says, thank you. In Ontario, the government does not respond to all our requests for coverage for liquid hydromorphone. Mm-hmm. Do you have any suggestions for how to get this very conservative government to get engaged or care or even respond?
Yeah, so hydromorphone's not that expensive. It's not that expensive. So I'm pretty free market based. And so I would probably just develop a fundraising strategy to buy it yourselves, and then start reporting on the outcomes. And I'd probably just start purchasing it yourselves. The government might cover it, but it's a legal drug in Canada. And so there's ways that you can do that through, you can start pressuring the feds. I don't know about the Indigenous population there, but having it on the formulary for non-insured health benefits can help with First Nations folks and prescribe it. But if the provincial government isn't willing to provide it themselves, I would be funding it ourselves. I think sometimes it's scary to think about doing that, but you could spend a year fundraising, building up a nest egg, and then if you got a proper investment strategy, you should be getting dividends on that return enough to fund that program on an ongoing basis. But oftentimes we get focused on we got cash, we'll spend it immediately. You might have to take a year or so building up a fundraising strategy, and not a fundraising strategy, but a fundraising base, so that you can start funding it. And it might not be that you can put 100 people on the program. Maybe all you can afford year one is with a little bit of nest egg to ensure that year two is going to go ahead. Maybe you can put on 20, and then that 20 becomes a pilot. Partnering with universities is a big one for studies. You could also partner with pharmaceutical companies on those studies, because if you don't think big pharma wants to get involved in safe supply, you're crazy. And so there's lots of options for pilot projects and those types of things. And you'd be surprised at how much government gets on board when the pharmaceutical companies start saying, give me.
Thank you, Jason. We have a question from Jillian. First, a comment. That was amazing. So many of the attendees today, excuse me, work in addiction medicine and harm reduction. What advice do you have for those of us trying to stop the stalling you spoke of in the response to the opioid crisis?
Yeah, so that's a tough one. A lot of it depends on the regional context, but there's some foundational principles that I carry with me when I'm looking at the stallers, and that's make a plan to go ahead without them. And yeah, like people always tell me it's not as simple as just going ahead, but it really is. And so if you have the policymakers and the decision makers that aren't willing to drag your heels, there's a couple things you can do. One is stack the board. Every organization, doesn't matter where it is, has a board of directors. So if you're working for an org that is stalling it, stack the board. So start getting people that think like you need them to think on the board of directors, and really start to go after it that way, so that from a decision making down, it's a directive that's given to the executive director and the staff. The other is you might have to make an offshoot of your program. So a good example of that was when the OPSs were happening in Toronto. They just started popping up, and it was really like a coalition of the willing to get that done. You might need a doctor. But you look at what's happening to be a prescriber or something like that, if it's a medical safe supply program. But you look at what's happening in Vancouver with Dolph. Like they're not asking permission. And yeah, I think if governments can listen to some assholes in trucks, why can't they listen to us?
I don't know if there's more to explore, Jason, besides the comparison between the 2000s diner, maybe at least go to the 1990s and a hipster cafe. But do you have any, could you expand a little bit more about the dynamics between opioid agonist therapy programs and safe supply programs?
Yeah, I think IOTs are they're good. It's a tool in the tool belt, right? And so I think when you're looking at them, but I think too often, methadone, methadose, Suboxone, those types of programs are being pitched as safe supply. And we've seen the harm reduction movement get co-opted by non-harm reductionists, just basically claiming everything they're doing is harm reduction, so they can potentially be in the queue for the next federal grant or whatever. And so I think that those programs are needed, they're maintained. What I don't like, and I see this very often, is the power brokers on those programs, the controllers, whether it's the calls physicians and surgeons, whether it's the physicians running it, they start attacking safe supply programs. And they start saying, these don't work, mine works. Motherfucker, if methadone worked, we wouldn't be in this situation. Like I'm not saying it doesn't work for some people, but it doesn't work for everybody. And that goes back to you have to have different strokes for different folks. So different options. If I looked at this, I have a lot of analogies that I use when I'm looking at these types of these issues. And when it comes down to the war on drugs, although it's been in place for a long time, I look at the strategies that we're implementing and the tech that's being developed, and not just the pharmaceutical, but even from a methadone standpoint. There's a methadone clinic here in the city that we were running into all these issues with people losing their IDs that were homeless, and so they couldn't get their methadone and staff turnover. So they just bought a fingerprint machine so that when somebody goes in there, they scan their fingerprint, they get their drink, and then they go on with their day, or they're even with their pills or whatever. They can even do their antiretrovirals that way, and even stuff like hydromorphone they can do that way. And so when I look at the tech that it's developing at the pace that it's developing, it often reminds me of World War I, but methadone is a really good foundation for how we were dealing with this issue, this war, this addiction, this overdose crisis. It was really good. But it's basically the equivalent of only in World War I, where they only had run out of the trenches, and then you have your gun. It only shoots so far. You got to run up and get through the barbed wire and then shoot them. And then we wonder why people are dropping. And the new safe supply programs that we're seeing develop, there's some really good stuff in Southern Ontario. There's some good stuff in as I was saying, in Calgary, and there's some good stuff in Vancouver. The Air Force has arrived. The Navy has arrived. Yet we're still only trying to respond to it with this IOTS program because it's comfortable for governments. But 10 years ago, governments didn't want to even embrace methadone. And yet sometimes the physicians that are being the prescribers are having trouble. The people that are the prescribers are having trouble adapting to the new way. And they forget that they had to fight to get methadone accepted. into the politicians' ears. And now we're in the exact same situation with the safe supply program, where we're having a fight to get it accepted, but it needs to be, just like methadone or methadose or Suboxone needed to be. And so it's not an either or. And I just think if you're involved in methadone works for you, or it's working for your patients, that's amazing. That does not mean that you have to try to sabotage the safe supply program. But oftentimes people treat it like it needs to be.
I think we have a good follow-up question for that, because it sounds like sort of, one of the dangers of medicalization. So this is a question from Nanki. Thank you for your clarity. Can you speak to some of the dangers of medicalized models of safe supply, especially when they end up replicating the same oppressive harms people who use drugs face when interacting with the healthcare system?
Yeah, I think it goes like, I think medical safe supply can work for some people. And that goes back to, you need different approaches to how it's developed. I don't think all medical safe supply are bad. I think it works for some people and it doesn't work for others. And that goes back to, we need to have multiple models, whether it's a street-led safe supply program or a peer-led safe supply program, a medical model. We still need abstinence and recovery. You need multiple approaches for people. If we're going to have an individualized healthcare, we need to have individualized healthcare. And so I've definitely seen medical models work. I've definitely seen them become super paternalistic and not work. And then they kind of get people hooked, and then people are screwed if they try to go off of it. And so I think it's something to consider. I think it's something to consider when developing it. But that goes back to having people who use drugs at the table. And it might not be that you need to redesign that medical model safe supply program. It might mean you need to have a new adaptive model that's developed and implemented around the same time, which can be a scary thought when you're overseeing a program, or maybe you're a physician lead on a program. That just means extra work. And I think nobody on this conference is struggling for workloads. I think if anything, everybody's overworked. And so I think that's where the problem is. But I think when we're looking at, I like medical models that are more led by nurses or nurse practitioners, and maybe overseen by a physician. No offense to the physicians in the room, but sometimes that personal touch is a little bit lost. And the eyes and ears, I don't find, are as open around physicians as they are around nurses. And so that's kind of my opinion on that. But I think some models work, some don't. Some work for some people, they don't work for others. But we might need a new model that's peer-led or whatever in that community to be more responsive to it. And that goes back to keeping up with the times, constantly updating our service delivery models so that they can keep up. And it's tough because we see the urgency, and maybe you were like, hey, when I was running the consumption site, people kept saying, okay, we want all this data released. And I said, we're not going to really get a good data set until it's like 2 years in. And then that's that by the time that data set gets studied and analyzed and put out, it's no longer necessarily relevant. It's like a little piece of history that we can look back on and say, oh, that was neat. But the 2 years the 2 years since the data came out and the 2 years since the report got released, it's completely changed as well. And so that goes back to constantly needing to update the programming that you're delivering on, and it's easier said than done.
Thank you, Jason. It seems like we're getting a theme that we need to foster different kinds of programs that can serve different kinds of people at different times. I think. And I think that's very much needed, because you're not saying that medical models don't work, but they don't necessarily work for everyone.
Yeah, we don't. And it's just within the movement, this happens when social movements take off. There's infighting. And that goes back to who's at when do you have those closed door conversations so that it isn't us versus them and it's us supporting them, and I think medical models work. Like in Saskatchewan, we're developing a medical model for safe supply. I think they work, but they don't work for everybody. And so that goes back to the need for peer-led programming and peer-implemented stuff. And, we had Kaput out here a couple of weeks ago, and we purposely developed a two-tier approach for our safe supply. Peer-led one, medical model one, because you need both for different reasons. Some of it's political, some of it's yeah. So it's not that medical models don't work. And I think I purposely talked about it like that way, because as medical community leaders, oftentimes we don't hear the message. And the getting into the bathwater around the coffee shop, I think, was probably clear, like a sentence in what I was actually talking about. But oftentimes we don't think about it outside of our context, and we don't think about how if we're applying our values and our operations and our governance, if we're applying it in another setting, what that would actually look like. Because we, in medical community, we can maintain for a long time, because once you get those long-term government contracts, they're pretty hard to pull away. And so the incentive to update and adapt and change is not there as it used to be when you were trying to get the thing off the ground.
Thank you so much, Jason. That was fantastic, thought-provoking, I think inspiring for so many people who are here. You brought a different flavor and a different approach, I think, to addressing opioid-related harms and opioid use. I'll note there's, some of the key principles you talked about, approaches that you talked about harm reduction and decriminalization. There are other talks through at the conference today that will be addressing these, and encourage everyone to look through the agenda. We'll be, I think, closing off this session now. So thank you so much.
Thanks, everybody.